بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا رب العالمين. Dear colleagues, now we are going to handle one of the important topics in the head and neck imaging, which is the maxillofacial trauma. You know that the face is one of the commonly injured parts in the human body, and is frequently assessed by imaging, especially in our days by the CT scan. And in order to have the CT examination for the maxillofacial area, we may have the slices at 3 millimeter in interval. We may examine the patient in the supine position, starting parallel to the level of the hard palate and going up until we reach the end of the frontal sinus. And in the coronal planes, we usually start from the apex of the orbit posteriorly, and you proceed anteriorly until we finish the region of the frontal sinus, and the scanning plane is usually perpendicular to the hard palate. Then we use the soft tissue and bone window images, and we use also the bone algorithm for bony details. We may include the mandible and the frontal sinuses, but you know the most important area or the commonly injured area, which is the mid face, as I will mention. Then as in every part of the head and neck imaging, we should ensure as much as we can the symmetric patient position. And here the 3D images are very valuable for assessment and orientation of the fracture lines and the separation and so on. You remember that I always mention that 3D imaging is almost of no value anywhere in the body except in the maxillofacial area. We aim from imaging to detect the fracture lines, to detect soft tissue injuries, especially the orbit, and to look at if there is any intracranial abnormality. Then from the anatomic point of view, the face is divided into 3 parts. The division lines, the first one passes just below the orbital roof, and the second one passes through the alveolar margin. So we have the upper face, which is made of the frontal sinuses, the frontal bone, and the orbital roof. The lower face, which is made mostly by the mandible and part of the alveolar margin. And the mid face, which comprises most of the other facial bones, including the maxilla, the zygoma, the orbital walls, the nasal bones, the ethmoidal air cells, and so on. Then we may have a quick look on the normal anatomy of the maxillofacial area. I have mentioned these anatomic details before, but you start at the level of the hard palate, then you see the hard palate, and you see this is the root of the maxillary sinus on both sides, and this is the mandibular ramus, and this is the small bone is the styloid process. And here is the maxillary antrum and the pterygoid bone with the pterygoid blades, and this is the start of the bony nasal septum. Then this is the maxillary antrum on both sides, the bony nasal septum, the inferior nasal turbinate, the medial pterygoid blade, the lateral pterygoid blade, the ramus of the mandible, the styloid process, and the cervical spine. Then going up, you can see the zygomatic bone, and this is the maxillary sinus, the lateral pterygoid blade, the medial pterygoid blade, and the pterygoid fossa in between. This is the nasal septum, the cartilaginous part anteriorly and the bony part posteriorly. Then you see the ramus of the mandible is dividing now into the mandibular head or the mandibular condyle and the coronoid process. Then this is the mandibular condyle, which will articulate with the temporal bone into the temporomandibular joint. Then this is the zygomatic bone, and here is the zygomatic arch. These are the nasal bones, and this is the bony nasal septum. Then going up, you will see the ethmoidal air cells and the sphenoidal sinus, the lateral orbital wall and the nasal bones. Then you see the orbit, you see the sphenoid sinus and then the ethmoidal air cells. And finally you came to the frontal sinuses. This is the left compartment, the right compartment, and there is a small osteoma on the right side. And in the coronal planes, you start posterior to the sphenoid sinus near the orbital apex. And this is the sphenoid sinus, and this is the floor of the sinus and the roof of the nasal fossa. This is the bony nasal septum, the pterygoid blades on both sides. And here is the maxillary antra, orbital floor, orbital roof, ethmoidal air cells, and this is the bony nasal septum, inferior nasal turbinate, middle turbinate which is pneumatized, concha bullosa, and this is the middle turbinate which is not pneumatized, and here is the hard palate. As I have mentioned, the 3D reformatted images are extremely valuable in assessment of facial injuries, especially in complex fractures, as I will mention. Then what is the aim of imaging? I have mentioned to look at the fracture sites to assess orbital pathology, injuries, and intracranial abnormalities. And is imaging of the maxillofacial trauma is urgent or not? According to the situation, we should have urgent study to look at the bone fragments in especially in vital areas like inside the orbit and also inside the brain, to reduce fractures before adhesions, to release muscles before fibrosis like the extraocular muscles, to seal the skull floor defects before meningitis, to ensure patent airway, which is very important, and to remove foreign bodies before infection. Then maxillofacial fractures are divided into three main categories. The simple fractures, which involve a single bone, for example, fracture of one of the orbital walls, fracture of one of the sinus walls, fracture of the nasal bones, or the zygomatic arch. Then the complex fractures, which are a group of fracture lines that can be classified as a separate entity, like the most common zygomatico-maxillary complex fracture, nasoethmoidal fractures, nasofrontal and nasomaxillary fractures. Then the extensive or transfacial fractures, which include the famous Lefort fractures and the smash injuries, then unclassified and multiple fracture lines. And starting by the nasal fractures of the nasal bones or simple fractures, and the most common example is the fracture of the nasal bones. The nasal bones are the commonest to be injured in the face because it is the most prominent and the thinnest bones in the face. Then it may be fractured as a single type of fracture or may be associated with other complex injuries. Then if you look to this reformatted CT image, and you can see lines, radiolucent or hypodense lines going vertically through the nasal bone. These are sutures. Fractures of the nasal bone should be perpendicular to the direction of the nasal bones in almost all cases. Then this is the normal appearance of the nasal bone, and this is also the normal appearance in 2D sagittal reformatted image. Then this is a good example for fracture of the nasal bones by plain X-ray. And you should know that all longitudinally oriented radiolucences represent the sutures within the different parts of the nasal bones, while the fractures will pass perpendicular to the direction of the nasal bones. And this is a comminuted fracture of the nasal bones, as you can see by this plain X-ray. Then fractures of the nasal bones may also affect the nasal septum, and one of the known lesions in the nasal septum is what is called septal hematoma. And here you can see that the bony nasal septum is markedly swollen, and it is fractured, and you can see this soft tissue density represents a septal hematoma. This hematoma will interfere or may interfere with the blood supply of the bony nasal septum, leading to cartilage necrosis, and the hematoma may be infected, leading to bony nasal septal abscess, and may organize with impairment of respiration. This is a fracture of the nasal bones by coronal CT image and an axial image, and also the sagittal reconstructed image. Then this is was just an example for the simple fractures. Actually, if any single bone is fractured, we call this a simple fracture. Then we came to the complex, and I will discuss in details this very important one, which is the zygomatico-maxillary complex fracture. And this fracture is the second most common facial fracture after the fractures of the nasal bones. And you know that the zygomatic bone, and this bone is attached to the face through 4 attachments. And you see the zygoma is attached to the frontal bone at the frontozygomatic suture in the lateral orbital wall, and is attached to the maxilla at the zygomatico-maxillary suture in the anterior wall of the maxillary sinus, and is attached to the temporal bone through the zygomatic arch in the zygomatico-temporal suture, and is also attached to the sphenoid bone through the zygomatico-sphenoidal suture, which is located in the orbital floor and along the posterolateral margin of the maxillary sinus. Then whenever the zygoma or the face is traumatized, the zygoma itself is not fractured, but it will separate from its 4 attachments. It will separate from the zygomatico-frontal, the zygomatico-maxillary, the zygomatico-temporal, and the zygomatico-sphenoidal attachments. And the zygoma, after being separated, it will be displaced and may be rotated as well, as I will mention. Then this fracture was previously known as the tripod or trimalar fracture. This tripod fracture because they thought that the zygoma have only 3 attachments to the frontal bone, to the maxillary, and to the temporal bones. They did not appreciate the attachment to the sphenoid bone. Then now the fracture is known as the quadripod fracture, or better, it is known as the zygomatico-maxillary complex fracture. You know that the infraorbital foramen, this foramen, is located near the fracture lines, and this foramen may be injured, resulting in injury of the nerves there in about 94% of zygomatico-maxillary complex fractures. That before the era of CT, we used to use this view, which is known as the sinus view, looking for possible fractures in the face. And you can look at the maxillary sinuses for opacification or air fluid levels, and you can also look for the fractures and the foreign bodies. And we at that time used to use what's known as the elephant head, and this elephant head is just the appearance of the zygoma. This is the zygoma, which is normal on the left side. It is attached to the frontal bone at the zygomatico-frontal suture and here at the zygomatico-maxillary suture, and here at the zygomatico-temporal suture. Then the elephant head should be of a smooth configuration, and whenever there is disruption of any of the outlines of the elephant head, we think of maxillofacial fracture. As you can see here, there is some deformity here, and there is some separation there, and the zygomatic arch is fractured here compared to the opposite side. Then this was the only way to judge the presence of zygomatico-maxillary, to judge for facial fractures. But after the availability of CT, we were able to look more better at the fracture site, and to look at the different fracture lines, also to look at free bone fragments. Then, for the diagnosis of the zygomatico-maxillary complex fracture, the zygoma should be separated at its 4 attachments. The zygomatico-maxillary means disruption of the anterior wall of the maxillary sinus. Zygomatico-sphenoidal, disruption of the posterolateral wall of the maxillary sinus. Zygomatico-frontal, disruption of the lateral orbital wall. And zygomatico-temporal, fracture of the zygomatic arch or disruption of the zygomatico-temporal suture. Then you have the 4 components of zygomatico-maxillary complex fracture on the left side, with some surgical emphysema or subcutaneous emphysema. And then the coronal images are usually valuable for evaluation of orbital floor injuries, which are common. They are not part of the fracture, but they are commonly associated with zygomatico-maxillary complex fractures. In this case, the orbital floor is intact, as you can see here. This is a nice image of 3D reformation for a left-sided zygomatico-maxillary complex fracture. And you see there is separation of the zygoma at the zygomatico-frontal suture, at the zygomatico-maxillary suture, at the zygomatico-sphenoidal, and the zygomatico-temporal. You can easily appreciate marked displacement of the zygoma and the lateral rotation of the zygoma as well. Then if you look here, there is fracture of the anterior wall of the maxillary sinus, posterolateral wall of the maxillary sinus, the zygomatic arch, and upward you see fracture of the lateral orbital wall. Then you got the 4 components of the zygomatico-maxillary complex fracture. And also here you can see fracture of the anterior wall of the maxillary sinus, posterolateral wall of the maxillary sinus, zygomatic arch, lateral orbital wall. These are the 4 components of the fracture. You see a surgical emphysema in the preorbital area. You see comminuted bone fragments, and there is fracture of the orbital floor, which is not a component of the zygomatico-maxillary complex fracture, but an association. Then whenever you diagnose zygomatico-maxillary complex fracture, and you have to look at posterior displacement of the zygoma, medial or lateral rotation of the zygoma, and associated orbital injuries, which are common in about 1/3 of the cases. Then here you see fracture of the anterior wall, the maxillary sinus, posterolateral wall of the maxillary sinus, and the zygomatic arch. And if you go up, you will see fracture of the lateral orbital wall. Then, how can you judge posterior displacement of the zygoma? You compare the zygoma at the fracture site to the opposite zygoma, and you can see that it is posteriorly displaced, and this is a common displacement because of the direction of through. Then how can you judge that the zygoma is rotated? Look at the maxillary sinus on the same side of the fracture. If the sinus is smaller than the opposite one, then the zygoma has rotated inside the sinus, meaning that medial rotation. But if the sinus is larger than the opposite one, This means that the zygoma has rotated outside, and this is lateral rotation. But if you see that the maxillary sinus on the fracture side is almost of the same size compared to the opposite, then the zygoma is not rotated. Okay, then here you see this is the maxillary sinus, and there is fracture of the anterior wall, fracture of the posterior wall. And one issue to be mentioned, if you see that the zygomatic arch is bowed like this and you consider it fractured, then the maxillary sinus here is smaller than this one, then you know that the zygoma is posteriorly displaced compared to the opposite side, and is medially rotated as well. Then here the maxillary sinus is larger than the opposite one, and the zygoma is minimally displaced posteriorly and laterally rotated. There is fracture of the anterior wall, posterolateral wall, lateral orbital wall as well. Now, in this zygomatico-maxillary complex fracture, the zygoma is displaced posteriorly and medially rotated because the maxillary antrum is smaller than the opposite one. And you see free bone fragments within the sinus, which are not a big issue, but free bone fragments within the orbit are very important. Also, you can see the fourth component of the fracture, which is fracture of the zygomatic arch. Then higher up you see the fracture of the lateral orbital wall. Then after surgical repair of the zygomatico-maxillary complex fracture, the main issue of importance for the surgeon is, number one, to get the zygoma back to its normal position, almost in the same plane of the opposite zygoma, to prevent facial deformity. And the second important issue is the sealing of the orbital floor, because if the orbital floor is defective or fractured, this will enable the orbital contents to herniate into the maxillary sinus, and this may result in severe visual disabilities, starting from diplopia and ending by blindness. Then, if you are confronted by a case like this, forget about these comminuted fractures. Forget about that the zygomatic arch is still fractured. All these are nonsense. You only concentrate on your report at the position of the zygoma and the sealing of the orbital floor. These are the very important issues. Then this is the fracture by 3D before surgery, and this is the reconstruction after surgery. Then we came to another fracture which is also important in the face, and this is the nasoethmoidal orbital fracture. And this fracture, the trauma is in the central part of the face. It will involve the nasal bones and the ethmoidal air cells, and also some of the orbital walls, particularly the medial orbital wall. Then this is central trauma will result in collapse in an accordion fashion appearance with, as you can see here, the trauma to the face is central, while in cases of zygomatico-maxillary complex fracture, the trauma is off the midline towards the site injured. Then here you see comminution of the nasal bones and the comminution of the ethmoidal air cells, as well as comminution of the frontal sinuses, including the medial orbital wall. Then if you see orbital emphysema, you should think that the origin of this emphysema is from the ethmoidal air cells, and that's to say there should be comminution of the ethmoidal bony margin or the lamina papyracea, the medial orbital wall, as you can also see here. Then in the coronal plane, you will see comminution of the ethmoids, which are totally opaque due to hemorrhage inside the ethmoids. Also, you can see hemorrhage in the maxillary sinus and in the sphenoid sinus in the axial image as well. Some of air has leaked intracranially, and there is pneumocephalus And you look here and you can see injuries of the region of the cribriform plate of ethmoid, as well as fracture of the orbital floor on the right side. Then this is an ethmoido-orbital fracture with collapse of the ethmoidal air cells, and this is not an acute trauma. You see the patient is examined sometime after injury, so you got resolution of the facial edema, and still you see the collapse of the ethmoidal air cells. This is also another example. You see fractures of the nasal bones, ethmoidal air cells, the comminution and hemorrhage inside the affected ethmoids. There is also fracture of the orbital roof and on both sides, and this is fracture of the nasal bones. And this fracture is usually associated with too many other injuries, like of course orbital fractures, especially the medial orbital wall and the orbital floor, in about 94% of the cases. It may be associated with the 4 types of fractures, as I will mention, may be associated with CSF rhinorrhea because of injury of the cribriform plate of ethmoids, and the frontal sinus fractures may be seen in about 25% of cases, loss of vision in about 30% of cases, and nasolacrimal duct injury and the nasofrontal duct injury. Then we came to a famous facial fracture, which is known as the blowout fracture of the orbit. This blowout fracture of the orbit will result from a blunt trauma to the orbit by an object that is larger than the orbital rim, so that the traumatizing object cannot get into the orbital cavity. It will hit the orbital bony margins, compressing the globe posteriorly, increasing the intraorbital pressure, resulting in rupture of one of the orbital walls, which is commonly the orbital floor. Then it is a good policy whenever you are confronted by an X-ray like this for a patient with trauma to the face, and you look here, there is fluid level in the maxillary sinus, which may be due to sinusitis or maybe due to hemorrhage inside the sinus. But this finding is very important. You see a soft tissue shadow which is hanging from the orbital floor. This is most likely representing some of the orbital contents herniating into the maxillary sinus. Then you confirm this by CT, and here you see there is blowout fracture of the orbital floor, and some of the orbital fat is bulging into the roof of the maxillary sinus. But one of the important anatomic structures here is the inferior rectus muscle. You should look for the state of the inferior rectus muscle in any case with maxillofacial fractures involving the orbit, because this muscle, if there is a rupture of the orbital floor, it may herniate into the maxillary sinus and become entrapped within the fracture edges or incarcerated. Then urgent surgery is needed to release the muscle to prevent diplopia. Then here is a blowout fracture by MRI T1 weighted image, and you see the fat is only bulging into the roof of the maxillary sinus, but the inferior rectus is intact. And this is a severe case where there is total loss of the orbital floor and herniation of the globe itself inside the maxillary sinus, and this is a severe form of injury. Then sometimes you got rupture of the orbital floor, and the inferior rectus muscle is well above the fracture site, but it is diffusely swollen, and this is due to contusion or hemorrhage. Then if you look carefully, you will see that the lateral rectus and the inferior rectus are swollen, and this is because of post-traumatic muscle contusion. Sometimes the blowout fracture will affect the medial orbital wall. Then the medial orbital wall will be fractured, and the muscle that will be entrapped here is the medial rectus muscle. And you see here the medial rectus muscle is markedly displaced within the ethmoidal air cells. And also here on the left side, you see fracture of the medial orbital wall, and the medial rectus muscle is entrapped within the fracture. It is markedly swollen due to muscle hemorrhage and contusion. In this example also you can see the medial rectus muscle is entrapped within an ethmoidal fracture, and the muscle is relatively swollen compared to the normal opposite side. Then optic nerve injuries are usually the sequelae of penetrating orbital trauma, especially the gunshot injuries. And it is almost very rare to see an injury to the optic nerve by blunt trauma to the orbit. And this is the firearm injury to the left orbit with possible disruption of the optic nerve in this particular area. Then there are a lot of orbital soft tissue injuries in the course of maxillofacial trauma, starting by ocular lesions, optic nerve, muscle entrapment, carotid cavernous fistula, and periorbital hematoma, which is the most common, of course. And you see here there is a large soft tissue mass that is covering the anterior aspect of the orbit, and this mass represents a hemorrhage and contusion of the preorbital soft tissues. Then one of the serious injuries of maxillofacial trauma is the globe rupture. And here you see that the right globe has been ruptured, and the signs of globe rupture that I have mentioned before, they are four. The number one, the flat tire appearance of the globe, collapse of the globe, thickening of the posterior sclera, and you see the posterior sclera is markedly thickened, then haziness of the inner scleral margin, and you got intraocular air. And the intraocular air is a sure sign that there is a globe rupture. And this is also a case of ruptured globe on the right side. You got collapse of the right globe and the irregularity of the ocular wall, and there is some thickening of the posterior sclera, but you cannot see an intraocular air. This air is entrapped between the eyelid and the anterior aspect of the globe. Then if there is an intraocular foreign body, this means that the globe has been ruptured, and you see intraocular hemorrhage and some thickening of the orbital walls. It is worth to mention that intraocular hemorrhage or the vitreous hemorrhage is not a sign of globe rupture, but it means that there is a serious ocular injury. And in this case, you see a hemorrhage in the posterior chamber, and then you don't see the lens, which is dislocated with possible laceration of the cornea and periorbital soft tissue edema and contusion. Then here is an example of vitreous hemorrhage, and the globe is relatively small, and you see the hyperdensity within the vitreous itself. And sometimes you got corneal lacerations, and these lacerations are easily diagnosed by simple inspection of the patient. Here you see the anterior chamber is intact, but in this area you see loss of the anterior chamber, and the lens is almost exposed to the external environment. And this is also a case of corneal laceration on the left side, and there is periorbital soft tissue edema and hemorrhage. And these are some of the injuries to the lens. You get subluxation, you get dislocation of the lens, and you get fragmentation of the lens. All these can be seen in the course of maxillofacial trauma. Then we came to the last group of fractures, which are the transfacial, and this type of fracture of fractures is the most important one, which is the Lefort type of fractures. René Lefort is a French surgeon, has divided the transfacial fractures into three groups. The group 1 is known as the Lefort type 1, which is known also as the floating palate injury. Group 2 is the pyramidal fracture, or type 2. Group 3 is craniofacial disjunction, or the type 3, which is the severest one. The most important finding for a diagnosis of Lefort fractures is to look at the pterygoid blades, and these are the pterygoid blades in the coronal images, and here the pterygoid blades in the axial images. All types of Lefort fractures should pass through the pterygoid blades in order to consider them as Lefort fractures. Then starting by Lefort type 1, and this is known as the floating palate because the fracture line involves the alveolar margin just above the palate, and the fracture will proceed from anterior to posterior until it hit the pterygoid blades. Then this is the sagittal image, which is good for delineation of this fracture, which is passing above the alveolar margin into the root of the maxillary sinus, reaching posteriorly the pterygoid blades, which are disrupted, and you got some hemorrhage inside the antrum. And this is also another example. You see the pterygoid blades are fractured, and you see the fracture line passing above the hard palate, and because it's known as the floating palate type, and here the fracture will involve the root of the maxillary antra on both sides. And this is known as the Lefort type 1 fracture. The axial image shows better the fractures of the pterygoid blades, which can be also seen in the coronal images. And this is Lefort type 1 fracture, the axial, the coronal, and the sagittal. The sagittal images are somewhat better for evaluation of these fractures. They are passing at the root of the maxillary sinus, just above the level of the hard palate. Then we came to the Lefort type 2, which is known as the pyramidal fracture because of its shape. It will affect the root of the nose, it will affect the medial orbital wall, the anterior wall of the maxillary sinus, as well as the middle part of the zygoma and ethmoidal air cells. Then you can see that this fracture does not affect the lateral orbit nor the zygoma. Then the 3D images are very important for appreciation of the fracture lines. And here is a typical pyramidal fracture passing at the root of the nose, medial orbital wall, anterior wall of the zygoma, until it is completed as a pyramid. But in the axial images, you will see fractures of the anterior and posterolateral wall of the maxillary sinus. You should assess the pterygoid blades for fractures. And this is the classic 3D image of a pyramidal fracture or type 2 Lefort injury. And you see the fracture line and the direction across the face. Then the most severe one of these fractures is the Lefort type 3, which is known as craniofacial disjunction, because there is almost complete separation of the face from the cranium. And to appreciate this fracture, you add the type 2 Lefort fracture plus zygomatico-maxillary complex. And if you see a zygomatico-maxillary complex fracture with the type 2 Lefort fracture, Lefort type 2 plus zygomatico-maxillary complex equals Lefort type 3. This is an extensive facial injury. It will affect both maxillary antra, the nasal fossa, the bony nasal septum, the zygomatic bone, the zygomatic arch, the ethmoidal air cells, the nasal bones. All these will be fractured. And because this is an extensive injury, it may be associated with globe ruptures. And this globe is intact, surrounded by hemorrhage, and this globe is ruptured and is occupied by a hematoma. And this is the to appreciate the fracture and its distribution. There is separation of all the mid face from the cranium. This is better seen in the 3D reformatted images. And this is an extensive fracture. Whenever you are confronted by a case like this to report, then you should start image by image and state the fracture lines. And here, comminution of the alveolar margin and the hard palate, comminution of the medial parts of the maxillary sinuses, the bony nasal septum, separation of the zygoma bilaterally, and comminution of the medial wall, comminution of the pterygoid blades, and the separation of the zygoma bilaterally, comminution of the ethmoidal hair cells, and you see also fractures of the zygomatic arches, and you can see here the soft tissue window images will show hemorrhage, extensive hemorrhage in the sinuses and in the nasal fossa as well. Very importantly is to evaluate the globes for the possibility of globe rupture, and this is very important. And you see here the globe is intact and the opposite globe is also intact. Then going up, you may see fractures of the frontal sinuses, which is not a part of the fracture. It is an association, which is a common association with Lefort type 3. Then Lefort type 1 is the simplest. It is known as the floating palate. It passes just above the alveolar margin and the palate, involving the roots of the maxillary antrum. Then the pyramidal fracture, which is Lefort type 2, and the craniofacial disjunction, which is the Lefort type 3. And you should know that all these fractures should affect the pterygoid blades. Of course, the René Lefort is stated that for each type of the fractures there is symmetric injury on the left side as well as on the right side. But nowadays you see that you can see Lefort type 2 on the left side and Lefort type 3 on the right side, or Lefort type 1 on the right side and Lefort type 3 on the left side. Then smash injuries are extensive facial injuries that usually result in the wars, and due to explosions the fractures are not classified. They are extensive, and you usually see some of the radio-opaque fragments of the foreign bodies residual within the affected area of the face. But you have to say that there is extensive comminution, and you say what are the bones that are comminuted here. The mandibular ramus, and there is affection of the alveolar margin and the maxillary sinus on the right side, the zygomatic bone as well. Then the maxillary antrum, the ethmoidal hair cells, and the lateral orbital wall, as well as the ethmoidal complex. Then here are the coronal images, and you see comminution, and you see the extensive injury. Very importantly is to look at the orbital contents, and if there is possible herniation of the orbital structures into the maxillary sinus. And there is a comminution of the orbital floor, but the inferior rectus muscle is still at its anatomic site. Then CSF rhinorrhea may complicate maxillofacial trauma, and it usually results from injuries at the orbital floor, particularly the region of the cribriform plate of ethmoids. And in the era before MRI, we used to have this examination, which is known as CT after myelography. We inject the contrast media intrathecally, and we scan the patient looking for the dribbling of the contrast opacified CSF through the defect in the orbital floor. And this is a very big defect, which does not need actually to examine the patient with myelography, and they see the contrast material is leaking into the ethmoidal hair cells. Then sometimes you got herniation of the brain tissue itself. If the defect is big, like this one, and you can see pneumocephalus and downward herniation of the brain tissue into the ethmoidal complex on the left side, and this may be better appreciated by MRI, since you can see the brain tissue with the characteristic cortex and the gray matter herniating through the defect in the floor of the anterior cranial fossa. هذا وبالله التوفيق والحمد لله رب العالمين. Thank you very much.